Alrighty. To start off, we'll just do a little review, very small, because this is what I find that people kind of struggle with sometimes. It's the GT PAL. So, oops, getting it this time. All right, so gravida, of course, number of births. And remember, whenever we're talking about twins, always count it singular, and unless we're talking about living children. Okay, and then of course, T is term, between 28 and 42 weeks. I found that para is, well, P right there is preterm on the top one. Preterm is usually going to be, of course, less than 20 weeks. I'm sorry, more than 20 and less than 27, because if it's less than 20, it's then abortion, whether it's therapeutic or spontaneously. Of course, that was living. We have an example there, but we'll just look at it when we go review. But the difference between para is, just got an email. Para is the number of times a woman has given birth at least 20 gestational weeks, counting multiple births as one birth event. I did do a little drawing. I know my handwriting is terrible, but here's a little visual for those that, I mean, it's just kind of bring it together. Just recognizing that abortion, it's either going to be abortion or preterm or term, but the word that kind of overarch is when we're talking about para being more than that 20. But yeah, pretty much it. This should be a really easy question.
Para, if the baby goes past 20, para is like 1 and then term would be 1, right?
Yes. But recognize that when we're talking 39 weeks, it would be a P for para, but it would not be a P on preterm. So you have to read the question.
Okay.
Yeah, so like back over here, I already have the answer. I already had it written down, but I pulled that from a textbook, I believe. And T equals 1 daughter, born at 40 weeks. P would be 1, the son born at 34 weeks. P being para there. Abortion, 1, abortion at 8 weeks, and L is living 2. But I don't know, it's always going to give it to you. It should, but I guess just kind of look at your answers, because I know sometimes on practice questions, sometimes they might have GT PAL and they'll just have the G and a P, but you don't know what the P is. Is it para? Is it preterm? So we have more abbreviations. SAB is a spontaneous abortion. PTL, I'm glad that the question was asked last week. PTL is usually going to be preterm labor, 37 weeks and before. UPI is uterine placental insufficiency. So the placenta is not doing its job correctly. Intrauterine growth retardation. Otherwise, I always think of it small baby. That's usually due to minimal chronic small oxygen perfusion. IUFD would be intrauterine fetal demise. So the baby has passed away, the fetus has passed away. These are just little words that, for our luck, they won't, I mean, you're probably going to have it on your test somewhere, but it's not going to be a definition question. It'd probably just be, I don't know. It would just be helpful to understand. You're going to see PTL definitely a lot this semester as we talk about things that can kind of occur or result in preterm labor. Okay. Maternal nutrition. Normal pregnant women require an additional 300 calories a day. And that need is, of course, needs to be higher within the last 2 trimesters. We did talk about the weight gain with a little trick to it, and it's kind of funny, it's still on the wall here. But remember that whenever we're talking about weight gain, a little trick to kind of get a little insight would be to take the number of weeks that you are. So for example, 30 weeks, they're going to subtract 9, and that should be like a plus or minus 2 area of our weight that we're going to want to be at. But pretty much what this is with our BMI here, it's kind of saying, if I remember, if the lower your BMI is, the more weight you need to gain to kind of provide for pregnancy. And I can tell you, I've had a lot of questions on past point and whatever, just practice questions we're doing, and they're always kind of talking about that. Kind of the issue with when we have mothers who are, the age of less than 18, less than 20, is their body's not able to kind of provide that. And a lot of them usually are underweight as well. If breastfeeding, they are going to need an additional 500 calories. Dietary concerns. Protein, you pretty much always can get away with going off that it's going to be red meat. Red meat's a good protein source. It's always better than broccoli. Tofu is also a good protein as well, although it's not red meat. And if you cook these in an iron skillet, it can increase iron, but just a little heads up there. Grains would be whole grain, not refined. Fruits would be the entire fruit, not the juice. I remember Harold even telling us with, of course, our lettuce, it shouldn't be the shredded lettuce. It needs to be the whole thing, the romaine lettuce. Yeah, no raw meat or raw fish. It needs to be medium to well done. Of course, we have a dietary concern with pica, and the definition of pica is really just when they're eating foods that aren't of any nutritional value. A lot of times with pica, you can have someone like eating ice, just to kind of, I guess, satisfy that need, but it isn't giving anything nutritional value. Iron, take it with vitamin C, not milk. And you can always, it's always good to kind of have folic acid, as that is proven to kind of help prevent neural tube defects. If you need an increase in iron, a lot of times prenatal vitamins can be taken. And one note that I have here is we need to avoid mercury whenever we can. Okay, anemia. Iron deficiency anemia is the most common, often decreasing the iron in blood. Another ways that we can kind of be anemic is if we have our pregnancies too close together. The body just doesn't have enough time to recover. Those kind of make sense. We've talked about how your H&H do decrease during pregnancy, so it needs to kind of recover there. Anemia does increase the risk of postpartum infection. Just knowing that our white blood cells are even decreased as well. And our patients that are specifically at risk for anemia problems would be our adolescent mothers, maybe pregnancy spaced too close together. Their H&H hasn't had enough time to kind of go back to normal, or maybe they're twins as well. That's what multiple gestation is. Signs and symptoms of this would be like fatigue, they have a headache, or if their hemoglobin is less than 10. And I have that kind of typed backwards. Maternal weight gain, here we go. We've already kind of talked about this, again, with the little line trick, but this slide just kind of breaks it down with what they actually are, kind of serves in that entire thing. The average weight gain, if you had a question on this, remember it would be 25 to 35 pounds. Thankfully, that little line trick always can help you. Yeah. And again, if Harold's ever giving you guys different numbers, please go off of hers. She's the one making the test and stuff like that. Vaccines. This is a big chart here. We're not going to talk about all of it, but we're going to talk about what we have typed here. The rubella vaccine is not given during pregnancy. It is a live virus that does cross the placenta. And after pregnancy, we need to wait 1 month. That'd be the 28-day month. want our moms to get the flu shot. It can't give the nasal shot. No nasal flu shot, but a regular flu shot is okay. We do want them to be immunized. Let's finish it. Recognizing that the kind of chart with this is live viruses can cross the placenta, but large things like our bacteria, that's not going to cross. And one common vaccine that we'll usually test about is MMR, measles, mumps, and rubella. But understand that is a vaccine that we never give during pregnancy. And we even have it on this chart right here on the left side. Measles, mumps, and rubella, contraindicated. Also chickenpox, contraindicated as well. And it's really just all in this chart here. Kind of brings it all together. Just going back to the old stuff where we're talking about what does and does not cross. That usually can help you with knowing what vaccines we're going to be able to give. Okay. GBS, British streptococcus. This is the leading cause of neonatal mortality. This is transmitted to the infant during the birth canal, during delivery. This is actually what we always test, when you guys go to clinical. Can't wait till you guys can go. But they're going to test, and you'll see it on the prenatal chart, if they are positive or negative. All pregnant women should be cultured between 35 and 37 weeks. Where we get problems with that is when we go into preterm labor. If the mothers haven't been able to be tested. If they happen to be positive, they're usually going to have some IV antibiotics going as well. And then we have to be observant with possible sepsis and things like that for our neonate after birth. The drug of choice we'll be doing for this will be penicillin for mother and the baby if needed. Pregnancy at risk, pre-gestational. Rheumatic heart disease, congenital heart defects. We have highlighted here that warfarin is contraindicated in pregnancy, but its little counterpart, heparin, would be safe. Heparin would be safe. No, you're good. I don't know how much I've blocked out on the fill in the blank for this spot, but yeah. Normal pregnancy causes an increase in heart rate. Usually their cardiac output is increasing. They're giving more, it's going to a different area of the body. Of course, blood volume is increasing as well. And I'm sure one also will teach you about why the H&H is going to go down. That's because, think of it as you're taking a sample of, I think of sweet tea. If it's really diluted, the numbers are going to be lower. So that's kind of what happens there. But yeah, we do have 3 periods of increased risk of problems. During that first 8 weeks, we're talking about the placenta. The big focus is on making sure that the plasma is increasing. And then, of course, postpartum, that's what PP means. We're concerned about blood loss. Anything more than 500 with a vaginal birth would be red flag for a potential postpartum hemorrhage. And then for a C-section, it's going to be 1,000. Okay. This stuff is just what we have typed up, but it's we'll just kind of go over a little bit, mainly with the interventions, where we want to make sure that we have a low sodium diet, that we're not avoiding excessive weight gain. So within our 9 rule, maintain bed rest, and of course lying on the side, but lying on the left side, on the back. Diabetes, usually we'll screen at the 24 to 28 weeks. We've talked about how back in the day they used to go and eat pancakes. Now they're doing the glucagon test. The risk factors of this, if they're of course older than 25, maybe they have a history, maybe they're overweight, whatever it shall be. Complications of this, though, are our big one would be neonatal hypoglycemia. Hypoglycemia could cause very well a lot of different things, even brain damage as well. But pretty much our moms with gestational diabetes have a high risk of babies with really blood sugar issues. Pretty much they've been swimming in lots of sugar, and when you get out of that, you're like, hey, where's it all at? You know, they're just hypoglycemic, really bad with that. The body's still making insulin, whether they come out for the amount of sugar that was there before. That's what it's doing. So the body's, out. It's saying, we're still going to make all this insulin, but we didn't know that you're not going to be in all that sugar. So kind of a sign and symptom of this would be jitters. They're not eating a lot. They may be very still, maybe lethargic, and their color could be off. Kind of teaching with this would be during the first trimester, insulin, those amount of insulin needed will usually decrease. And then whenever we're talking gestational diabetes, really there's a lot of teaching with that. With gestational diabetes, this could be something that even goes into maybe like a preeclampsia or something like that as well. Those are usually come together. Okay. First trimester, again, insulin needs are low, so they can kind of cut back on the insulin. But of course, they might be using a sliding scale if they're type 1. The last trimester, the insulin needs to increase as glucose and glycogen storage by the mother and fetus increase. HPL again is being produced from the placenta, and this will usually cause resistance to the mother's insulin, which is that's kind of why we're needing to increase the glucose. The demand. You have gestational diabetes, you can get it again, and you could even have a risk of after that going into type 2 diabetes, which would not be fun, I guess. All right. Next, we kind of talked about this already again, but it's very important with this. RH factor and of course, sensitization or desensitization. Of course, if we have an RH mom and an RH negative fetus, we're kind of chilling, we're okay. If we have an RH negative dad and an RH negative mom, we would also be kind of okay because the risk of having an RH positive fetus would be very rare. Remember that with this whole type of thing, the mom is treating the fetus's blood like a foreign body, like if it's an invader, an antigen, and the first pregnancy is always okay, but pretty much the mom is making antibodies if exposed, and it's really important that we do RhoGAM for future pregnancies. Our slide was pretty much on our last PowerPoint, so we're going to keep going. RhoGAM, again, remember, is not given to mothers who are already sensitized and have antibodies. Please highlight that. It just, you're going to have these tests here, possibly, and it'll give you the result. So also recognize what these tests are. The indirect Coombs test is the one on the mother, determines if the RH factor is negative or pretty much if they have made antibodies. So if we have a positive indirect Coombs test, pretty much reminding me where we're getting there. But we also do have the direct Coombs test. This is performed on the infant, their blood up to birth, to identify if the antibodies have attached to their red blood cells. And also with some teaching, this is usually given at 72 hours after birth and usually on the 28 weeks of pregnancy, if we are already aware of the blood types. And of course, even after an invasive procedure or maybe potential exposure, maybe like a car accident or something as well. HIV, no breastfeeding. The first bath is immediately after birth to remove the maternal blood, and we're giving those injections after the bath. Usually HIV will have a C-section, that's what cesarean is. We do not want to have any procedures that will puncture the skin of the baby, including avoiding fetal scalp monitoring. That is the med here, retrovir, that we're giving during pregnancy. And then it's during the L&D process, and it's giving during IV to decrease transmission. These patients use them standard precautions. What else is there? The fetus can't really contract this through the breast milk. I'm sorry, they can contract this from the breast milk. That's why we're not doing the breastfeeding as well. Again, remember, no bath. HIV is spread through bodily fluid. Syphilis, this does cross the placenta, and we're treating again with penicillin. They're tested at 36 weeks of gestation, but the difference from this one is we're also treating their partner as well. Okay, Hep B, hepatitis B virus. This is very common in our fetus. This is transmitted by, of course, blood and bodily fluids. This can go through the placenta, and it can be given as well off during our pregnancy delivery process. This is not contraindicated during pregnancy. I know it's kind of hard to read, but this is the one that we are going to give the vaccine for. So what we'll do is we'll do the HBsAg, the hepatitis B surface antigen. And infants born to HBsAg positive mothers should be treated within 12 hours of birth. And overall, all STIs can have implications on the fertility and the pregnancy process. If you have a bad placenta, or you could also, it could kind of decrease the risk of you, not risk, but chance of you getting pregnant. And it could even change the delivery method where we might be having to do a C-section. There we go. Substance abuse. Really, with this, we want to make sure we're having a trusting relationship with our mother, that they're being honest with us if they're doing anything. So you have to be really careful with how you kind of communicate with these moms. We have over here DC, that means discontinue. But we do have right here neonatal abstinence syndrome. This is kind of whenever they're very irritable, they're having an increased breathing reflex, they're kind of sucking, swallowing, not really coordinated. They're not even really swallowing a lot with regurgitating of foods. And really cocaine is the worst. Cocaine can cause preterm birth, and it's just because cocaine is a stimulant, and stimulants cause vasoconstriction, which therefore would even pretty much just cut off the oxygen supply to our placenta. The where's that at?
Oh,
Non-stress test. Cocaine can also cause preterm birth. The reason is because smooth muscles do contract as well when we're having these vasoconstrictions. And of course, contractions are usually associated with birth. Methadone is the med here, that's why I have it in pink. It's a longer half-life, it's low cost, and it removes the woman from drug-seeking activities. We are going to give this during pregnancy. We're not going to discontinue it. To switch over to alcohol, it's important to teach the mother that they are never drinking alone. Even after birth, with alcohol, no breastfeeding. A pump and dump, you pump your breasts and then kind of dump it down a sink or something. It's still going to be in there after that pump is there. So really, we encourage no breastfeeding, but to kind of help out even more, no drinking during that entire process as well. Okay. Of course, with alcohol, the first trimester is the most, that's what we have highlighted. This is the most dangerous because we're kind of developing all of our organs. That's pretty much it. If they're like partying or something like that, that would be a very bad sign. with alcohol in the second trimester, we do have a risk of spontaneous abortion. Sadly, that's the one that's you're going to see, or you very well could see at clinical. So remember, just be encouraging. Third trimester as well. If they're drinking late in the pregnancy, we could have some brain growth, brain kind of damage as well. So, and then of course, we learned about fetal alcohol syndrome, which is associated with lots of really neuro impairment as well. Okay. Cigarettes. Again, with all of these, trusting relationships so they can be honest. We want to make sure we're monitoring fetal growth. A lot of times cigarettes can have small babies because just the placenta isn't as perfusionable. I guess that's not really a word, but the effects of cigarette smoking could be constriction. So right away, whenever we're thinking constriction, we're thinking also with maybe a preterm labor down the line, decreasing uterine perfusion, fetal tachycardia. SA would be spontaneous abortion. You have stillbirths as well, if it's very early. And of course, decreased growth, so we're thinking small babies. Sudden infant death syndrome as well. That's what the SIDS is. It's not SpongeBob, but the SUDS. Only good one here, multiple sclerosis and rheumatoid arthritis. These are the only diseases that actually improve during pregnancy. This is due to the hormone that they're producing, relaxin. Both of these together are autoimmune diseases. But the sad thing is, even though this does improve during pregnancy, of course, after the whole delivery process, both of these chronic things can relapse postpartum. But it does, with the whole relaxin, and they're feeling fresh in that second trimester type of thing, could be doing well as well. Right. Miscarriage, also called spontaneous abortion, will be the loss of our fetus before 20 weeks. We've already talked about this, but symptoms of this would be bleeding, cramping, and a backache. Usually that's a lower backache. We want to make sure we're measuring the HCG levels. If they have decreased, the decreased levels indicate a miscarriage. And then they might even do an ultrasound to see that there's a heartbeat there or not. If the miscarriage is threatened, and we'll talk about that in the next slide. If it's threatened, bed rest is what we're going to do. If it's a threatened abortion, the client has vaginal bleeding, but the cervix is closed. So we want to make sure that they're on bed rest. Maybe we can kind of give it some more time. Not be in the hospital a while, but maybe we can kind of delay that pregnancy as well. And D&C is dilation and curettage. That's a very invasive procedure. We're going to go in afterwards and kind of, I've never seen it, but I know I've heard about it, and it's like where they're kind of cleaning up if there's any placental fragments pretty much in the uterus. Right. This is your types of abortions here. You don't need to remember this, but it very well could be on your HESI down the line. That's why I like to put it in here. Don't remember being tested in a lot of this, but it is very well to know. We have, of course, spontaneous. We've already talked about this. Induced would be a therapeutic abortion. A threatened abortion would be if they're just kind of spotting and they're cramping, but the cervix remains the same. If it's inevitable, it means the cervix has dilated, and of course, they're also effaced, which means it's thinning. If it is incomplete, that means there's loss of some of the products. An incomplete would be the client has been bleeding, cramping, maybe also an expulsion of part of the products of conception. The tissue remains in the uterus though, so it's incomplete, and the cervix is very dilated. Within the incomplete, a hemorrhage is possible because placenta is retained, and you'll learn later when the placenta is retained, a lot of bleeding does occur. We have a missed abortion. the client will have a decreased sign of pregnancy. As the fetus has already passed away in utero, this is the one where, you know, no heartbeat type of things like that. And they may be at risk of needing a D&C if products of conception are not removed. And then habitual, the word in there would be habit. That has occurred 3 or more times. Put in a question here. It's very small to read. I'm so sorry. Yeah, client comes to the ED, model vaginal bleeding. Gets a change of pad every 2 hours, and it looks like I passed some tissue and clots. He's 9 weeks pregnant. Wow. Further assessment reveals the following. She's dilated, so automatically we're thinking this is inevitable. Strong abdominal cramping. She has a low HCG level, which we've already, that's not the one we want. Ultrasound is positive for products of conception. Their successful woman is experiencing which type of a spontaneous abortion? This would be, yes, B, inevitable. And I even took it from the textbook, so it's very cool. That's like my source. Client comes to, with inevitable, we have a lot of bleeding. They've, of course, ruptured membranes. They're dilating, so it can't close. A lot of cramping. They may have a possible passage of products. And the ultrasound and the HCG it's been lost. Okay. Next is gestational trophoblastic disease. This one is also called molar pregnancy. But don't be fooled, the name, it is not a pregnancy. This is where we have an empty ovum actually with no genetic material, but it is a full edematous grape-like cluster of cells. These are usually abnormal precancerous cells or non-malignant, and this can develop into this word, but it's not really that important. We're really talking about this here. This will start like a normal pregnancy. They're having that morning sickness. They'll, maybe their uterus is enlarging, but it'll keep going. It'll just keep going. The uterus will just keep enlarging way too fast. They will have no fetal heart tones. They will start bleeding and hyperemesis. Nursing language, what would that be? Hyperemesis. Excessive vomiting. So usually this is associated with very high risk of dehydration, and we need to put IVs going and just get some fluids going. Confirmed with an ultrasound, but there is no fetal heart rate, vaginal bleeding, gestational hypertension before the 12th week. The fundal height is greater than expected because it is very fast enlargement. It looks like a snowstorm on an ultrasound. That's just what we've heard. And it is very, very high levels of HCG. So pretty much. And teaching of this, I know it's down here, but please remember this because this could be on anything that you're tested on throughout the whole semester. With molar pregnancy, do not get pregnant afterwards for at least a year. We need to make sure that we're healing our uterus, essentially. Okay, ectopic pregnancy is whenever we're having, I know we talked about in the beginning of the first day of SI, where it's like you want it to be implanted in a certain spot and all that. The ectopic pregnancy is whenever we have kind of implanted and it stays in the fallopian tube. Just imagine it. It can cause the fallopian tube to later burst. This is not a viable pregnancy. And if you have one, you will then at risk for another one down the line. So really, you would have to go through a lot of prenatal work to make sure that you're not having this again. Methotrexate is given to stop the growth of the embryo to save your fallopian tube. Surgery, if this doesn't work, you could even have to get your tubes tied the word for that as well. Here we go. Placenta previa. Placenta is implanted wrong. It presents in front of the baby. I have a really cool way to memorize this. Whenever we're talking, basically this, we're distinguishing between this and this. So maybe we should start out with abruption because it's easier to talk about. But with placental abruption, it's complete separation from the placental wall. We do have dark red blood, and you do not want to do a vaginal exam during this. All right, so pretty much the way I like to memorize this is you see the BR at abruption. We're thinking kind of a brownish colored blood, so dark red blood, very helpful. This one is the one that also hurts a lot. Sharp pain as well. So B for burden, but also brown blood, very distinguishable. But as the nurse, what are we doing? We are wanting to make sure we're not doing a vaginal exam because you don't want to make it worse. This will, of course, have a lot of different bleeding. And the reason this blood is very dark is because it's coming from the back. It's coming from the back of their placenta, okay? They're usually going to have board-like abdomen. So if you ever see that on any test moving forward, you have see anything like that, recognize that that is placental abruption. This is usually an emergency C-section as well. And if you have any question telling you, we have dark colored blood and we have patients screaming, it's sharp pain. What are we doing next? And you're like, well, choices are to do vaginal exam. You're going to say, nope. So let's go back to this one. Previa. This one's kind of the flip side. Usually have one and recognize the other, but P on the second word would be for painless. This is painless bleeding, and recognize that this is usually in the front. The placenta was implanted wrong, and it's usually presenting. It's the presenting part, so the placenta is kind of coming out first. This is when we're having a big gush of blood. It's very painless, and it's usually going to be bright red blood because this is in the front of our kind of presenting part. The placenta begins to prematurely separate when the cervix is dilating and efface. This is causing the baby not to get enough oxygen. And we would not want to do a pelvic exam of this. Okay. Normally, the placenta should be attached where up in the uterus, very high. The delivery method of choice for this would also be a C-section. But with pelvic exam, the pelvic exam may puncture the placenta, which would be a bad thing. And this would precipitate our laboring placenta. So basically, if you kind of puncture the placenta before the babies even come out, mom loses blood, baby loses blood. That's why you're not doing it. Okay. Do you think if you had this, you could kind of distinguish it? I'll teach you guys ways to memorize it afterwards. Okay. Incontinent cervix, that's whenever we are having our cervix dilating prematurely. Patient will have a history of repeated painless second trimester miscarriages. They're going to need that dilation in cerclage. Well, actually, this is a different word here. Cerclage is the kind of sewing, the reinforcement of our cervix. Sorry, I almost got that wrong. This is the suture to cervix to prevent a preterm labor. Their cervix is just dilating, so we need to kind of help them out. Sadly, the only way to kind of prevent this would be if they have them before, to kind of prevent the future ones. Painless cervical effacement and dilation that is not associated with contractions. This usually would happen in the second trimester. This usually does also result in a spontaneous abortion or a very, very preterm birth. Okay. We've already talked about this one, well, not really, but this is the one that's associated with our molar pregnancy. It's going to start like regular morning sickness, but it's going to go into excessive vomiting dehydration, starvation, and could even result in death. This is related to high levels of estrogen and HCG, the vomiting hormone, the pregnancy hormone that tests positive on our tests. Signs and symptoms of this would be a low blood pressure, a high H&H, low urine output, a low potassium, and then weight loss. We need to make sure these patients are NPO for 48 hours. We're giving, you have to remember these, both names, phenergan or promethazine. We're giving a quiet environment. We want to make sure they have correct oral hygiene. It's supposed to subside. The vomiting is supposed to subside, but in this case, it keeps going. The fetus is at risk of maybe IUGR, which earlier we talked about is intrauterine growth retardation, small baby, or death from the lack of nutrition, the lack of oxygen, and the lack of, I guess, nutrients as well. It could even result in ketoacidosis as well. These patients are going to need hospitalization, IV fluid therapy. They're going to need some glucose. They're going to need some electrolytes. Of course, with the potassium being low, and the vitamins to begin treatment. And then they can go home after that. We've talked about preeclampsia. Preeclampsia is the increase of blood pressure and proteinuria after the 20th week of pregnancy. You don't need to recognize the blood pressures, but usually it's going to be an increase of, I'd say, around 40 systolic. Signs and symptoms of this would be some visual changes, a headache, some edema, epigastric pain, maybe a sudden weight gain. They're going to be even more edematous. They're going to have hands and face swollen. They could have a headache, blurred vision, which usually goes into the visual changes. And then hyperreflexia, increase in the deep tendon reflexes. Also presenting with clonus, but really just knowing hyperreflexia, increased deep tendon reflexes. The babies in this are usually small for gestational age because of the intrauterine growth retardation, also about small baby. I always say this to kind of make it a little bit easier, but treatment of this, if it's mild, we're doing bed rest. We're going to make sure they're getting some protein because they're kind of peeing it out. We want to make sure they're monitoring their salt, maybe even an amniocentesis as well. If it's severe, though, this is where we're bringing in MAG sulfate. We want to make sure that this isn't going into eclampsia, which is where we're having seizures, and MAG sulfate is an anticonvulsant. But pretty much this. We're putting them in a single room. We want to make sure it's very non-stimulating environment, dimming the lights. But a complication of this would be HELP syndrome. Always HELP with 2 L's. Hemolysis, elevated liver enzymes, low platelets. I mean, it just recognize that HELP is a complication of preeclampsia. The only cure is delivery of the placenta, but I've even read on our NCLEX prep that sometimes after pregnancy, their blood pressure could still be going. They could still have, seizures and stuff like that. So it's not the only cure, but I guess it does kind of help. Yeah. Patients still at risk for seizures for up to 48 hours after delivery. And this used to be called back in the day, pregnancy-induced hypertension. Okay, MAG sulfate, CNS depressant to help keep having from seizures. You just really need to understand that this can be toxic. There's a therapeutic range 4 to 7, but over 9 would be toxic. Where we're usually worrying about urinary output because toxic levels in the body will increase that output. MAG sulfate also actually can be used as a tocolytic if we're giving them too much pitocin, oxytocin, and they're just having a very fast labor. We can give them MAG sulfate to kind of slow it down. Or if they're preterm labor, we can actually give them MAG sulfate to kind of prevent that as well. Recognize also if we have toxic levels, calcium gluconate is the antidote. So we're going to keep it at the bedside. And remember, when you're answering a nursing question, it's always at the bedside. It's always the perfect world. It's always going to be there for you. It's normal for a mag sulfate patient to have to feel flushed, relaxed, or lethargic. The baby's going to often be the same. They're not going to have accelerations of heart rate. But we're checking these things here. Okay, eclampsia, talking about seizures here. The occurrence of seizures in women with preeclampsia who has no other cause of the seizure. It's usually characterized by convulsions or coma. Usually increased DTRs, deep tendon reflexes before this will occur. That's why we're kind of monitoring that stuff. But as far as the test question, remember to monitor fetal heart tones, watch the labor progress, and watch for heart failure as well. But also, we're talking seizures, safety. We want to make sure we're patting the side of rails, maintaining the patient airway, but also recognizing we're not using a tongue blade. Sometimes you have questions on that, like that. So, yeah. Premature labor is when we're having 20 to 37 weeks of any time in that time span where they're going into birth. We're using often a tocolytic here. Tocolytics, just kind of get rid of that with that verbiage, but mag sulfate is again brought into this, and brethine, terbutaline. I know it's hard; those words are totally not the same as well. But if our patients are going into premature labor, we're giving them betamethasone, which is a steroid to kind of stimulate the maturity of our baby's lungs in case the preterm actually does kind of falter. Recognize that UTIs and dehydration, of course, can cause premature labor. And this just kind of goes back into those med search stuff that you guys are working on, but treat according to the culture. We're going to usually get a broad spectrum first. Well, usually how it's going to go is you're going to test, you're going to do those cultures, give a broad spectrum, and then once you get the results of that, then you're going to give the focused kind of antibiotics as well. Here is a complication of pregnancy kind of thing here. It just brings up, it's off of Google. So, okay, now you have some questions. It is okay if hot. And I know with this PowerPoint, I actually put in the next 40 slides are all questions because I wanted you guys to be ready for the test. And it usually does work out. Usually you guys are doing well, but this was a little bit harder, so I'll go and show the answer. It's going to drop significantly. And do you guys have this on your PowerPoint? These questions? Okay, I'll go ahead and if anything, we'll just have to, I'll give you guys the recording and the answers will be on there with the rationales. This is already on there, so no point in me reading it, but the kicker is when we're talking about the lessons here. Do we have a slight like a guess with this one? It would be A because the fetus could be Rh positive, so we need to know what that test will be so we can kind of go further. And then those levels are hemoglobin 12 to 16 in females, hematocrit 37 to 47. Bouncing off of the question we had two before, but what's the purpose of the HPL? Now remember, this hormone is the one that this one acts as an antagonist to insulin and makes glucose. I mean, it's usually the reason we could be having gestational diabetes. So it's decreasing that natural insulin level in the body. Back to last week's content. A presumptive, we have subjective in there, but I'm not sure if on the test you'll put subjective, presumptive. So remember that. C. This is not, we're going off of the not, so these from the book. So skin changes would be the not one. This is an objective probable change. Subjective, presumptive changes can all be caused by other conditions. So I guess quickening can be caused by something else, which is why they do that. This was a happy one. It's not too bad. Okay. This one's A. Another pregnancy test, if it's done by the mother or maybe mother, we don't know. It is actually not, it doesn't absolutely confirm it. And this is subjective. And of course, BCD or objective, those are, I'm sorry, diagnostic. Those are the, for sure, you're kind of pregnant. Oh, this one's a really hard one. I don't think your test would have something like this one, to be honest. This is SATA.
CH should be 25 to 35.
You guys are killing it. It was actually BDE. And we have all the rationales here, so it'll help you understand. Tidal volume does actually increases because oxygen consumption increases during pregnancy. The cardiac output does increase. We know that today. The average weight gain would actually be a little bit less than that, 25 to 35. I mean, just usually it's you follow the 9 rule. Increased vaginal secretions does occur. You have that thick, white, and acidic chorea as well. And then E, remember, whenever we're talking, I don't know if it was a thing of sugar and it's just a sweet tea or something, when it's very saturated and it's like a gallon, that H&H level will be very low, which is why blood's increasing, but the volumes have gone down. You know, but if they're bleeding a lot, H&H levels could rise, actually. Hall-Becky's gamma reveals a cervix that has purplish blue color. Which sign would this be? Very well. Anyone has any question on this? McDonald's is flexing fundus in the cervix. Latins, you wouldn't even have to know. Good old sign, it's softening of the cervix. And if you were tested on Hagar's sign, what is that? Hagar's softening of, yeah, uterus. Very nice. Or tricky one. I know the hormones are always the hardest out. Good news is I don't think it's on the NCLEX, but who knows? I'm not too sure, but I don't. I can come back with you guys on this one. Or maybe I had it typed wrong. Maybe I wasn't supposed to put estrogen there because I have B where it says this is the function of estrogen. I don't know. You thought it was D?
Yeah.
Okay. Well then, I guess nice. I don't. The hormones are always soft for me. The xiphoid process is high up there, so they've got 36 weeks. And it's usually only accurate with numbers of weeks, plus or minus 2, or of course, after 24 weeks. They made this thing really hard. See, if your results show higher than the normal alpha fetal protein levels, it may mean your baby has a neural tube defect, such as spina bifida. Okay. That worsening sign that as we're getting to eclampsia. I have a very long rationale here. It's kind of hard for you to read it, but a client has been admitted with a diagnosis of hyperemesis gravidarum. What would be the highest priority at this time for this patient? Fine, so you're vomiting, need to get that electrolytes back. Yeah. Nurse is imputing a prenatal client, which is the following factors would be with the nurse highlight.
Yeah.
That's when we're talking about toxoplasmosis. Because she's not going to know you know, that you can't be doing the cat litter type of thing. Someone could argue also one, but it's not that priority. Because remember, when we're talking about one, they're probably going to need a lot more education, need a lot more, they need to have a higher weight gain to kind of catch up. Let's read the rationale for this one. I'll get down to you. This big word, oligohydramnios, is when we're talking about amniotic fluid, and the O in it means we don't have enough. Think of it as hypo amniotic fluid, I guess, rather. So if it was polyhydramnios, we have a lot of amniotic fluid. That stuff will actually be later in the semester, but it was just meant to throw you off too. Cocaine. Cocaine uses, well, the use of it produces vasoconstriction. It could also increase their body temp. It will make tachycardia because it's a stimulant, everything's going up. And hypertension, again, everything's going up in the mother and the fetus. Placental insufficiency may result from this. Chronic use can also result in a low birth weight, a smaller head, circumference, and weight. So. They'll teach you one again. So.
Oh, I thought it was find the wrong answer.
Correct. Side effects of iron supplements are nausea, abdominal pain, constipation, and black stool. Attempting to meet maternal iron requirements.
Yeah. So you're supposed to take orange juice, right?
Yeah, the reason that's not A is because it says avoid drinking orange juice, but you usually want to take it with vitamin C as well. Find this more on page 711 of your book if you need to. You guys would love to have this question on your test. It is B. Remember we're talking about with the molar pregnancy, it's whether it's kind of like precancerous stuff going on. And just to make sure that it's a safe pregnancy after that, we want to make sure that they're not getting pregnant for at least a year. Okay, so we for sure at least know we're giving it after birth, correct? Okay, was it the 28 weeks that, but it is 28 weeks. Right now, the CDC recommends that Rh negative, non-immunized women, so non-sensitized women, receive RhoGAM at some point between 20 and 32 weeks. I mean, heck, it could even be 8, but it's talking about 32 weeks, but yes. Now, if it would have said a patient who's Rh negative but has already made antibodies, still give the RhoGAM? Nope. Okay. Client with severe preeclampsia is receiving MAC sulfate. Pulled from the book again. Calcium gluconate is the antidote for MAC sulfate toxicity. You see that I control that gluconate. I'm dead. It's okay. But that's pretty much. Of course, I mean that's all you're teaching for MAC sulfate right there. So I would check out the video and maybe write that down as well. And here's the end of our QR code. That will be back here.